Assalamu alaikum. Good afternoon, everyone. My name is Ahmed Kanabish. My topic today is going to be about the role of CT post-TAVI implantation. I think most of you are aware with the role of CT before the TAVI implantation. However, recently a radiologist from Bad Kreuznach Heart Center, he published an incidental finding in CT after TAVI implantation. He talked about a newly developed hypoattenuation along the TAVI leaflets. Afterwards, many publications showed that this is a new process and thrombosis and requires anticoagulation for those patients. This led to the increased role of CT after the TAVI implantation. My topic today will be divided into four main domains. I'm going to talk about the planning of the CT itself on the scout, as well as the technique, whether prospective or retrospective. I'm going to talk about the important points to include in our report, as well as at the end I'm going to talk about a very important point which has a very important clinical implication on those patients. The first point includes the planning of the CT itself. As you may see on the left side is the scout of the chest. On the right side is the scout of the chest, including the lines focusing only on the area of the aortic valve, focusing only on the area of the TAVI stent. Most of those patients have been exposed to radiation during the coronary catheter, during the CT preparation before the TAVI. Our role as radiologists is to decrease as much as possible the doses for those patients. Therefore, focusing only on the aortic valve area or on the stent would help, of course, to reduce the doses as much as possible for those. The CT techniques will include either a prospective technique or retrospective technique. Prospective technique, for example, like step and shoot, you will need only 2 steps. This will, of course, lead to decrease the doses about 50% in comparison to the retrospective technique. You will be able to identify any hypoattenuations along the TAVI leaflets, but you will be unable to identify the movements of the leaflets of the TAVI. You will be unable to report whether there is a restricted movement or a free movement of the leaflets of the TAVI. On the other side, during the retrospective, you will be able to identify the movements easily. You will be able to identify any newly developed hypoattenuation along the TAVI leaflets, but of course on the expenses of exposing our patients to much radiation. Our reports should include identifying any newly developed hypoattenuations along the TAVI leaflets. We should comment on the movements of the leaflets, whether restricted or free movements. If we are able to identify any leakage, this should be reported. In some cases, we will be unable to identify the paravalvular leakage because the artifacts from the stent or from pacemakers. We have to comment on the ostia of the coronaries, whether they are occluded or not occluded. The shape of the stent is very important to include in our reports. Starting with the first point, which is the most important. As you may see here, for example, this is a normal appearance of the leaflets post-TAVI CT, smooth. There is no evidence of any newly developed hypoattenuation along the leaflets, no evidence of any irregularities along the TAVI leaflets or along the stent itself. However, as you may see in this case, for example, there is newly developed hypoattenuation along the leaflets of the TAVI after implantation. This represents a case of thrombosis because this newly developed hypoattenuation was identified shortly after the implantation, less than 12 months after the implantation, and it is on the leaflets of the TAVI. This indicates a thrombosis and excludes a pannus formation. Another case where a a newly developed hypoattenuation was identified along the leaflets of the TAVI shortly after the procedure itself. This indicates also that this hypoattenuation is a thrombosis process. As you may see on the left side, this as you may see, this is a case of Pannas. The hypoattenuation was identified along the lower border of the stent only after 12 months from the implantation. And this is the opposite of the thrombosis. Thrombosis usually develops at the leaflet level shortly after the implantation. In some cases, Pannas might migrate from the lower border towards the leaflet. But usually the epicenter of this hypoattenuation will be at the lower border of the stent. I think those two important points could differentiate between the thrombosis and the Pannas. Another point to include in our report, whether the leaflet moves freely or restricted. If restricted, we have to describe which leaflet is affected. For example, in this case, as you may see, there is a newly developed hypoattenuation. On the left side, during systole, the leaflets are widely open. On the right side, as you may see, the leaflets are closing freely. This reflects that despite leaflet thrombosis, leaflets are moving freely. This indicates a case of subclinical thrombosis. The difference between subclinical thrombosis and clinical thrombosis, I'm going to mention it in the last two slides. As I mentioned earlier, that in some cases we will be able to see communication between the left ventricular outflow tract and the native coronary sinus. For example, in this case, on the left coronary sinus, you are able to identify a very thin or a very narrow communication between the left ventricular outflow tract and the native coronary sinus. This represents a paravalvular leakage. This case was confirmed lately or afterwards by echo as well as by cardiac MRI, which showed about 12% paravalvular leakage. Paravalvular leakage is a very important and a very common complication post TAVI. Therefore, it's very important to include in our reports if we are able to identify it. In some cases, because of the stent or because of the pacemakers or because of valve-in-valve, we will be unable to identify it. However, if we able to identify it, it's very important again to include in our report. The morphology of the stent itself at the leaflet level should be rounded. This indicates a well-inflated valve. Any disconfiguration, for example, an oval-shaped valve at the leaflet level is considered to be a disconfiguration. This might represent a high pressure or a high paravalvular leakage. Therefore, it's very important to include. Also, we have to comment whether the ostia of the coronary arteries is enough contrasted or not occluded or occluded. Until date, I didn't face any case with occluded coronary arteries because of the TAVIs. However, it's very important to include in our reports in order to exclude a complication or a potential complication that might. CT, of course, like any other modality, has its limitations. Artifacts because of the stent or because valve-in-valve in some cases will produce artifacts which would make differentiation between thrombosis hypoattenuation or metallic artifact hypoattenuation difficult. CTs through the retrospective gating exposes our patients to, of course, high radiation. In some cases, difficulties in the ECG gating because of arrhythmias will occur. A very important clinical point which is related to the movements of the TAVI leaflets is to identify whether this is a case of subclinical thrombosis or a clinical thrombosis. If CT is able to identify hypoattenuation along the TAVI leaflets with no restricted movements of the leaflets, this is a case of subclinical thrombosis and the patient should be arranged for a follow-up of this hypoattenuation without receiving any anticoagulation. On the other side, if CT is able to identify leaflet thrombosis with restricted movement of the TAVI leaflets, this indicates that this is a case of clinical thrombosis, and this patient should receive anticoagulation and of course will be arranged for follow-up echocardiography to show the pressure gradients along the TAVI, and CT of course to identify the progress or regression of the hypoattenuation along the leaflets. As you may see in this case, for example, there is a hypoattenuation along one of the leaflets. However, across the cardiac cycle, you can see or identify that the TAVI leaflets opens widely in the systole and closes freely during the diastole. This reflects a subclinical thrombosis. A CT follow-up was recommended for those patients, and he or she didn't receive any anticoagulation but was scheduled for the follow-ups of the CT. This reflects the importance of the comment on the TAVI leaflet movements and the post-TAVI CTs. Thank you.